right? The third reason may be that that's the only drug in that class that they know. Okay, so there can be reasons, practical reasons for people using certain drugs with a certain frequency. Okay, if we were in a perfect world, you would want to choose a drug that had a, think of it like a car, right? Had a performance rating that exactly matched your purpose, okay? If you wanted to get from point A to point B as fast as you could, all right, you probably would not pick a 78 Toyota Corolla in which to achieve that in, okay? If you could, you'd like to pick a 2007 Maserati, all right? That would serve your purpose much better. The same is true for drugs. Okay, it is not the second Tuesday of the fourth month, and so therefore we'll use thiopentothal for all of our patients that day. All right, you try again to match the drug with the clinical situation and the purpose that you want to use it for. Okay. When we think about that, we can call that a medication profile, all right? You think about what you want to achieve. What is your goal? Why are you using 1, 2, or a combination of 3 of these medications? What do you want to accomplish, okay? And you think about the specifics of that. Given your specific patient situation, what things do you want to avoid? All right, that is equally as important. If you have a kid who already is tachycardic, who is already exhibiting signs of shock, who is therefore already having perfusion problems, who is already hypotensive, seems to me you would certainly want to avoid using an agent that is known to cause severe hypotension. Yeah? Okay? So think about the pros and cons. Think about the characteristics that you want your medications to have. All right? Again, the specific things that you want to avoid. And from that list, all right, you pick the drug that fits it most closely, or the combination thereof. All right? So we'll talk about the drugs that we use most often, all right? And when we talk about a medication profile, again, the things that we're looking at are the characteristics of that medicine. The characteristics we care about is the onset of action, all right? How long does it take after I give this drug for it to become effective, okay? That's very important, all right? When does the peak activity occur? In other words, maybe, it starts being effective in 5 minutes, but clinically I'm not going to see that until 20, 30, 60 minutes, all right? So I need to understand that so that my expectations are realistic. The third thing is the duration. How long will my drug last? Again, that lets you anticipate. When am I going to have to administer another dose if I want to keep the same effect, all right? Or how long am I going to have to worry that I'm not getting the effect that I want, all right, until this drug wears off? The other thing is the side effects, which you can use to your advantage, all right? Or the problems, or what I like to call no-nos, all right? In other words, the no-nos are the things that, yes, I do expect you to have memorized, okay? There are certain drugs that do certain things that you must know about if you're going to be administering them. The dose range, okay? Probably the least important thing to have memorized, the thing that's most appropriate to have on your, flip chart, wherever you keep it, your cheat sheet, your peripheral brain, all right? And then one thing that we'll talk a little bit about is metabolism, okay? I don't expect you to know that. off the top of your head, again, it could be something that you could keep on your cheat sheet that perhaps would be to your patient's advantage to be aware of these things, all right? And it's because in certain cases it could make a significant difference. All right, so the list of drugs that we're going to talk about are fentanyl, Versed, thiopentothal, morphine, Ativan, propofol, vecuronium, rocuronium, pavion, and atracurium. All right, this is our armamentum that probably 95% of the time we use. All right, I didn't put ketamine in there, although if we have time, we can talk a little bit about ketamine, only because, again, it's a very interesting drug. It can be the most appropriate to use in certain instances. All right. So let's talk about the profile of each of these drugs. And what I'll do is try to write this and then perhaps erase it each time. Okay? All right, so let me get rid of this so it gives me a little more room. Okay. Let's talk about fentanyl, a drug we use multiple times every day between the ICU, transport, the ER, okay? The onset of fentanyl, very quick, all right? Probably about 30 to 60 seconds, okay? The peak, I would say 5 to 10 minutes, all right? And the duration, in general, fentanyl lasts less than 60 minutes, okay? Side effects. Now, the beauty of fentanyl, all right, or one of the advantages over morphine is that it does not cause significant hypotension, all right? For an equally effective dose of fentanyl versus morphine, your patient is going to experience less of a SVR, or systemic vascular resistance, change with fentanyl than morphine, all right? That's why we use it. That's why we like it, okay? So you're going to have less blood pressure problems, all right? It is potent, okay? If you have somebody who's experiencing pain and you want them not to, you will be able to achieve that with fentanyl, all right? Now, on the other hand, it's a big respiratory depressant, all right? You give enough fentanyl, your patient will become so happy that, yes, they will forget to breathe, okay? So remember that. In general, that's true for all the drugs in either the pain or the sedation profile, all right? Now, chest wall rigidity, okay? You should know this by memory regarding fentanyl. It's a quote, no-no now. In other words, it doesn't mean that you don't want to use fentanyl. We certainly use it all the time. It is just something that, as someone who administers fentanyl with any kind of frequency, you should know about this problem. After fentanyl first came out, it was noted that some patients were unable to be effectively ventilated for several minutes after a fentanyl dose was administered. There was a lot of discussion on this point in the medical literature, all right? Some people believe that it has to do not with the dose, all right, but with the rapidity of which it is given. In other words, if you rapidly infuse an appropriate dose of fentanyl, that the patient can experience chest wall rigidity. Now, nobody knows that for sure. I use fentanyl like water. multiple times, every day, all the time. I believe that I have experienced chest wall rigidity in my patients perhaps 3 times, all right, in about 10 plus years.